Good evening and thank you for joining us for tonight's update in partnership with St Vincent's Clinic, the CPD and Events Manager at Central and Eastern Sydney PHN. Before we begin, I would like to acknowledge the traditional custodians and sovereign people of the land across which we work. I recognise the continuing connection to land and pay respects to elders past, present and emerging. I also extend that respect to any Aboriginal colleagues who may be joining us tonight. Here are upcoming events which you may be interested in. Please visit our website to register or for more information, as well as the 2 remaining CPR courses that we offer Monday 14th of October and Monday 4th of November. Again, these details are listed on our website, so please visit the website. I would now like to introduce our facilitator for this evening, Vanessa from St Vincent's Clinic. Thanks, Vanessa.
Thank you, Bertha. Good evening, everyone. My name's Vanessa, and I'm the Marketing and Events Coordinator here at St Vincent's Clinic. I'm delighted to welcome you to our 3rd GP session with the CESPHN for the year. And here at St Vincent's Clinic, we have just over 300 specialists that are some of Australia's most well-known specialists. So really honoured to be part of the clinic. And I'd like to introduce you to our speaker for this evening, Associate Professor Nigel Biggs. He will be talking about his experience working with vertigo and managing Meniere's disease. Nigel is an accomplished otolaryngologist, head and neck and skull-based surgeon. He is an associate professor and has academic positions at the University of Notre Dame and University of New South Wales. He is also an active participant in outreach programs, particularly in New South Wales in Moree with the Aboriginal Medical Services, which is fantastic. Thank you, Nigel. And he leans on his multifaceted team in his approach to treating his patients. So he works with his speech pathologists, anesthetics team, and his audiologists as well. Thank you. As Bertha said, we will be having a Q&A. There are 3 different parts to this presentation. And at the end of each part, when Associate Professor Biggs finishes speaking, we will open up for questions just to break it up. And you can pop that into the Q&A box, which I will monitor. So over to you. Thank you.
Thanks very much, Vanessa and Bertha, and thank you very much for the invitation to speak tonight. And I'll hopefully not bore people too much. There's quite a big topic that we're going to cover, and I sort of will just let you know in advance. I mean, we're obviously not going to cover every aspect of vertigo and hearing loss, but we will sort of go a little bit deeper into Meniere's disease, because that's something a lot of people like to know about. And certainly I've sort of divided into 3 sections, as Vanessa said, so that hopefully we can have the opportunity to ask questions at the end of each section. So try and keep it interactive. Thank you very much. And we're going to talk about hearing loss and vertigo and a bit of a discussion about Meniere's. I too would like to acknowledge the traditional custodians of the land that I'm presenting on, the Gadigal people of the Eora Nation, and their the fact that they've cared for this land for countless generations. I don't have any declarations or conflicts of interest. So we'll talk tonight about hearing loss. I'll cover a little bit on types of hearing loss and assessment. We'll talk about hearing aids, sudden hearing loss. Then we'll go through some vertigo, a bit about assessment, what sort of red flags to look for, what are the common causes we might encounter, and then we'll go through a little bit more detail on Meniere's disease. So as I said, we'll at the end of each section we'll pause for a second. So hearing loss, you all know about. It is amazing the percentage of the world's population that is affected by hearing loss. It's almost 20%. And when you actually look at the World Health Organization figures, the fact that over 1 billion people have some sort of hearing loss and over 400 million have disabling hearing loss, that's an enormous world problem. So it's not something that we can ignore. As you know, it's most prevalent in the elderly. The older we are, the more likely somebody's going to have some hearing loss, and certainly over the age of 50, over to the age of 70, I should say, more than half the population have some sort of hearing loss. And of course, we've got an aging population these days who are living a lot longer, so we're seeing a greater incidence of hearing loss in our older populations. Of course, hearing loss has significant impacts both in children and adults. In children, it's language and speech development, it's educational development, it can lead to behavioural issues, and we also can't ignore the long-term socioeconomic impacts of hearing loss. I went to an Indigenous ear health conference last week up in Newcastle, and it was interesting just hearing one of the cases given was a girl who of Indigenous background who had a significant hearing loss, and really she was so embarrassed about it. She refused to sort of do anything about it. She couldn't actually pass her HSC exams, and of course that then has implications in her later life, not being able to complete her high school. So we can't forget the long-term impacts. Fortunately, in children, we can mitigate most impacts if we recognise the hearing loss and we act on it. We can mitigate a lot of these impacts.
Sorry, Nigel, I'll just interrupt. Someone in the chat just said if you could turn the volume up, if that's possible.
Oh, that's a good question. I will see if I can.
Okay, feel free to continue.
Let me just try the Zoom audio. Can you still hear me?
Yes,
Yep.
all good.
Yeah, okay. I'll try and get a little bit closer so you can hear me better. So hearing loss in children, most common thing, of course, we would run into would be otitis media, or otitis media with effusion, which is glue ear. That's when the otitis media has been present for more than 3 months. And as you know, that's treatable. We often consider grommets in that situation. Fortunately, for the other common cause of childhood hearing loss, which is genetics, we have universal neonatal screening. So we can generally pick up those children who are born deaf, and we can intervene early. And we're fortunate in Australia that, you know, provision of hearing aids is free for those up to the age of 25 through Hearing Australia. And it's a reasonably good system to manage childhood hearing loss where hearing aids are required. Hearing loss in adults, probably a little bit less talked about than in children. There's a lot of emphasis obviously on children, but you know, as I said, we've got the aging population, and the hearing loss impacts can be several. Certainly can affect mental well-being. The cognitive effects has been in the media and the literature a lot more recently with the elevated risk of dementia. I'm sure you've all had patients coming in saying, oh, I've been told I've got some hearing loss. Am I going to get dementia? And of course, it's not that direct a link, but it is considered a risk factor in dementia. But yes, some of the audiologists, I think, do scare some of the elderly patients. The stigma, of course, we've all had patients who know that they need hearing aids and, of course, don't want to wear hearing aids because it's a sign of getting older. It can reduce self-esteem, and certainly in the elderly can lead to reduced social interaction, loneliness, and of course that's then plays back into the cognitive impacts of hearing loss. And a lot of this is well established in the literature. When we think about hearing loss in adults, like in children, we're thinking about, is it a temporary hearing loss? Is it a permanent hearing loss? And of course, what sort of hearing loss is it? Is it a conductive loss? Is it a sensory neural hearing loss, or is it a mixed hearing loss? And you're well aware that there's a huge range of etiologies of hearing loss. In adults, presbyacusis or age would be the most common, and noise damage is the second most common. Chronic ear disease certainly accounts for some, and we do see the genetic influence on some adults. There are many genes involved in hearing loss, and we do know some adults will get early onset age-related hearing loss, and though we may not have identified the gene, it probably has some genetic inputs. So if we're dealing with conductive or mixed hearing loss, there's a number of possible treatments, but the concept of conductive or mixed hearing loss is it should be treatable, hopefully, but not always. If it's simple things like middle ear effusions, which adults get just like kids, we can put in grommets. If it's a perforation, we can repair the perforation. If it's cholesteatoma, which I've got a little picture of there, of course, that's more chronic ear disease, and that's going to need major surgery. Unfortunately, patients with cholesteatoma often do end up with some residual conductive hearing loss, even with treatment, or other conditions such as otosclerosis, which, as you probably aware, is an onset in people's sort of 20s, 30s or 40s, where they've got no prior ear disease, but they just present with a conductive hearing loss. So conductive losses and to some degree mixed losses are amenable to surgery. But sensory neural hearing loss, which is probably the most common thing that you're going to encounter in adults, we're really left with sort of hearing aids. And when I see somebody with a sensory neural hearing loss in my rooms, I'm going to try and assess how severe they are. And the classic, of course, is an individual walks in and says, "Oh, I've been told to see you, I've got some hearing loss." And the family member walks in and the individual says they're absolutely fine, they're coping well, they're hearing everything they need to hear. And their family member looks at you and says they're as deaf as a post, they really can't hear everything, and can you please do something about it? So clues to sort of how severe somebody's loss is before you get the audiogram, can be the simple interaction in the consultation. If the patient walks into the rooms, if you're talking to them and they're not looking at you, are they picking up what you're hearing? I always ask the patient how do they go with a telephone, because a telephone is a pretty good test of hearing. And I'm not talking about using it on speakerphone, but if you hold a phone to your ear, you're really just using your hearing. There's no visual cues. You can't read lips. You're really just listening to speech, which is complex tone. So it's a pretty good guide. And if somebody can't use a telephone in one or other ear, then that's a sign of a pretty significant hearing loss. So telephone's a good guide. Television, certainly lots of people will put captions on. Even people with good hearing sometimes put captions on. As I said, the family perceptions are a pretty good guide as well. And also activities, is the individual not doing certain things? Are they saying to you, look, I don't bother going out anymore because it's all just too hard because I'm not hearing everything? So these are the sort of guides you might get as to the severity of somebody's hearing loss. So as I said, unfortunately with sensory neural hearing loss, people don't have a great range of choices. If it was simply a sensory neural loss where they could only have difficulty with a television, but otherwise they were okay, they could look at just getting good quality headphones for the television. But generally, people are going to start looking at hearing aids. I see lots of people who have been told they need a hearing aid. And, from my perspective, I'm really just checking them out medically. And I have a pretty standard sort of spiel that I give to my patients about hearing aids. And the things that I sort of tell them is I'm not aware that any brand of hearing aid is any better than any other hearing aid. Whether or not they want to get a Phonak or an Oticon or whoever, there's some slight sound characteristics to different brands, but we're not aware as ENT surgeons that one's better than the other. However, two ears are better than one. There's no doubt if you aid both ears, you're increasing or maximizing somebody's function. I am got to be careful about how I say this, but I often tell patients that they don't have to buy the absolute top end hearing aid spend the most amount of money that they've got on a hearing aid, because twice the price doesn't always make you hear twice as well. Hearing aids do come in different shapes and sizes, and some do have more functions than others, but there is quite a range. Unfortunately, Australia pays a lot of money wholesale for hearing aids, so they're relatively expensive here in Australia. But the hearing aid companies do have a bit of control over the price as to what we pay. So yeah, so I'm always sort of counselling them and not feeling like they have to buy the most expensive hearing aid there is. And I also point out that despite all the advertising, hearing aids are very non-specific amplifiers. So they do just amplify all sound that comes to them. You can control the sound a little bit by what's called a directional microphone. But if 10 people are talking to the one individual with a hearing aid, it will amplify all 10 voices. So all hearing aids have a little bit more difficulty in excessive background noise, and I'm not aware of any hearing device that doesn't have that issue. Whether or not somebody gets a behind the ear hearing aid or in the ear, so that's, you know, that's what BTE and ITE stand for. The fitting of the hearing aid, whether or not they've got Bluetooth or loop attachments, we very much leave that up to the audiologist to talk to the patient about. But you do sometimes encounter patients who have had hearing aids fitted and they say, look, I'm still struggling in group situations and things like that. And there are these systems called FM systems, such as the Roger pen, which are like remote microphones, and the individual can use that. It links to their hearing aid and it can provide a little bit extra processing power and puts the source of the sound a bit closer to them. So that can sometimes be a useful feature as well. So yeah, and then of course, I'm sure you're all aware that when hearing aids are not enough, or when people are getting beyond hearing aids, such as they can no longer use the telephone, even with their hearing aid in, or they've, our sort of general rules are if they've got less than 60% speech discrimination or a pure tone average of 60, 70 decibels, we'd be starting to think about things like cochlear implants. So, you know, I'm sure you're well aware of cochlear implants. If somebody's bilaterally deaf, and they're struggling in both ears, certainly an implant's going to make a huge difference to them. We do implant people with single-sided deafness. That's a much more quality of life decision. But what we're seeing more and more of these days in the aging population is people who are just getting perhaps beyond a hearing aid in one ear and they're just struggling. And in some of those individuals, we do consider a cochlear implant in their deafer ear, and then they continue with their hearing aid in their better ear. So age is not a limitation for cochlear implant in Australia. And if we actually look at cochlear implantation, it's the aging population who are the growing group getting implants. There's some always advances there. The new thing are the sort of single unit processors, which look a little bit better from the patient's perspective. But it's a big step. Cochlear implantation requires a lot more input from the patient and effort from the patient, but it's something that they can think about. So I thought I'd just also, while we're talking about sensorineural hearing loss, touch on sudden hearing loss, because that is something that presents, and from our perspective, we try not to miss particularly sudden sensorineural hearing loss, because it is easily missed. So if somebody does present to you with a sudden hearing loss, you know, the things that I'm thinking about is it an effusion? Is it an otitis media? Of course, what I should put in there is, I mean, it could be something simple like wax obstruction, and usually examination would make that fairly obvious. But the question in our mind is it a sudden sensorineural hearing loss? Because that's a relative ENT emergency. Often sudden hearing loss occurs after an upper respiratory tract infection, but you can get either an effusion or a sudden sensorineural hearing loss after upper respiratory tract infection. If somebody has significant vestibular disturbance or vertigo, that would be pretty uncommon in an otitis media. But if the patient has autophony, which, hearing their voice echo in their ear, or they're hearing pulsatile tinnitus, you'd definitely be thinking about middle ear causes. So they're probably more likely to have an effusion. And in the rooms, you can fairly simply, if the patient, you look in their ears look normal, and you're thinking, oh, the patient's complaining of a sudden hearing loss in one ear. If you look in their ears and their ears look normal, and you do a Weber test, and they're not localizing the Weber to the side of their deafness, then you should be very concerned they've got a sudden sensory neural loss. Weber tests are very sensitive for conductive losses. So if somebody's got a middle ear effusion or any fluid or otitis media, they should localize that Weber to the side of their deafness. So if they're not doing that, I'd be quite concerned about a sudden sensory neural loss. So looking in their ear and doing a Weber test can give you a fair bit of information there. If you do see somebody with a sudden sensory neural hearing loss, even if it's on the weekend and you're pretty convinced that's what it is, we'd always say, look, commence some oral prednisone, and then you get an audiogram, in the next day or two, if it takes a couple of days. We'd rather start the prednisone early and then adjust it accordingly, rather than patient presents late without having had treatment. We certainly would recommend referral if somebody has a sudden sensory neural hearing loss. We would always recommend that the patient has an MRI, but the MRI for a sudden sensory neural hearing loss is not an urgent test. We'd often just want to treat them first, and then we'll organise an MRI. We want to do an MRI of the IAMs, or internal auditory meatus, which means there's fine slices through there. A standard brain MRI, you've just got to be a little bit careful that it's not quite thick slices and misses things. Sometimes if the patients don't improve with oral prednisone, then we consider intratympanic dexamethasone injection. So the American Academy recommends this for salvage, in other words, if you fail. But sometimes with people with severe loss, we might inject steroids at the same time as giving them oral steroids. Or if somebody's diabetic or there's reasons they can't take oral steroids, we'd certainly look at injecting steroids. And hyperbaric therapy is also thought to be useful, but the difficulty with that is getting access to the hyperbaric chambers. It's a little bit controversial as to how effective it is, but it is recognised as a form of treatment. So that's a little bit on sudden hearing loss. That's sort of the end of that. Well, it's not just sudden hearing loss. On hearing loss, I've just touched on a few topics. I obviously haven't covered anything, but I suppose we should open it up to any questions if there are any.
Yes, we have a few. The first one is, what is your advice on how do you manage tinnitus?
Tinnitus, that's a real challenge. So I'm a subscriber of the central theory of tinnitus. So you're all aware of the auditory pathway. The cochlea converts sound into nerve impulses that goes into your cochlear nucleus and up through your auditory pathway in your brainstem. When I remove acoustic neuromas and I divide people's cochlear nerve, they still have their tinnitus afterwards. So I'm a firm believer that most tinnitus is central in origin. In other words, it's coming from your central auditory pathway. One of the theories behind tinnitus is, in fact, everybody's got the tinnitus signal. It's a question of whether or not you can hear it. And having a hearing loss does make it easier for people to pick up on the tinnitus signal. But the central theory goes to why there is no magic treatment for tinnitus. There is no pill that gets rid of tinnitus. So the keys to tinnitus management is, number one, ruling out any underlying pathology. Number two, counselling the patient, reassuring. I find explaining exactly our theory and understanding of what tinnitus is, demystifying it for the patient, trying to reassure them and reduce their concern is very useful. And most patients adapt and adjust over a period of time. But for those who are really not coping, and generally they will be patients with underlying anxiety or depressive issues, they can look at something called tinnitus retraining therapy, which is a type of cognitive behavioural therapy. There are a handful of good clinical psychologists around Sydney who specialise in managing tinnitus. But I really am strongly against trying to use medication for tinnitus because there's nothing that works, and the patient starts to spiral because they keep searching for a method of managing their tinnitus, which is the wrong approach. Sorry, quite long-winded, but it's a big topic.
That's okay. Someone called Asha has said, are cochlear implants government funded in these patients?
They are. A lot of the major public hospitals do have access to cochlear implantation. It's like a lot of public funding. It is not in children. It's absolute. Children in public hospital, any child born deaf will get 1, probably 2 cochlear implants if needed. Adults, the funding's a little bit less available. Most public hospitals, our public hospital has access to public funding cochlear implants, but it's just not open slather. We are lucky in Australia that the private health funds with the right level of cover do cover cochlear implantation, and they will cover both bilateral cochlear implantation and cochlear implantation for single-sided deafness, which is something that they don't do in the US, for example. So no, we're fortunate. We do have both public and private access to cochlear implantation.
Great. We have another question. Often patients have thick or hard wax. What are your preferred earwax drops? And do we still syringe after a few days of this? Or can it accelerate hearing loss or drum changes? What do we do?
Certainly we shouldn't accelerate hearing loss or drum changes. Drops are, look, your standard over-the-counter wax oil, Ceramol. I quite like getting patients to use olive oil if they've got dryish wax. And I like the old school dilute hydrogen peroxide, 1.5% hydrogen peroxide. If they've got that very wet, sticky wax, that can be quite useful. I think syringing, very happy for people to syringe ears in what we would say is a non-pathologic ear. In other words, a non-painful, non-discharging ear, and also an ear that hasn't had surgery. And the tips with syringing, of course, is make sure you're using sort of body temperature water so they don't get a caloric effect, being gentle and not aiming the tip of the syringe straight at the drum. You're aiming it at the roof or the floor of the canal to get a sort of vortex to wash the wax out of. Not using too much force.
Thank you. Asha has another question. Dose of prednisone in SSHL.
So dose of prednisone. The studies are not strong for prednisone, but look, we would start, the original study was 1 milligram per kilo. I think most people would start at 50 milligrams up to 14 days, but I would taper it down over 14 days. I'd normally start somebody on 50 milligrams for 3, 4, 5 days, depending on the severity of their loss, and then I would taper it down. But I wouldn't go beyond 2 weeks with oral prednisone. There's not much evidence for, when you look at all the studies, there's not really a lot of evidence for going beyond that or mega doses of prednisone. And it's pretty much a rule of thirds. About a third of people recover to normal, a third of people make a partial recovery, and a third of people don't recover at all.
There are a few questions relating to sudden sensory hearing loss. I'm assuming that's SSHL. Yep. I think you just answered those, so I won't go through them again. Someone has said, though, how long would the dose be for SSHL?
Yeah, up to 14 days.
14 days, okay. Another question, we've got 3 more. Does physio help tinnitus, as some physios with training in this would claim?
Physio, look, drives, I'm always saying to my patients, stressors aggravate tinnitus. Now, stressors can be physical, emotional, or psychological. And so neck problems, cervicogenic tinnitus is well recognized. So if the person has a particular neck problem, that could be driving their tinnitus, absolutely. I think physio would be useful from that perspective, but there's no magic physio exercise to get rid of tinnitus. But if it, to address the drivers of the person's tinnitus, yes.
Thank you. Another one on tinnitus. If it is central in origin, why does it improve with hearing aids?
Because you're basically what you're doing is you're just overriding the signal. So you're just driving more input through that ascending auditory pathway. So one of the theories is, when we think about, the cells in our brainstem, they're either passing on a signal or they're inhibiting a signal. And basically, if there's no input to that cell, it might drive its own signal. But if you're some inputs are inhibitory, and so that's why sound input can actually mask tinnitus, because it's got that inhibitory effect.
Thank you. And final question from Asha. What about patients with grommets and impacted wax? Can they be syringed?
Not really. Yeah, I would be looking at other methods such as suction or using a wax curette to remove it.
Okay, great. We can move on to the next section. Thank you.
Excellent. All right. Tell me to speed up if I'm going too slow. All right. So vertigo. So what is vertigo? And it's important to understand that from our perspective, it's a symptom. It's not a condition. Vertigo is really the term for an active sense of rotation. When we all see patients with dizziness, that's a much more vague and nebulous term. It can mean a huge number of things when somebody says they're dizzy, and it's really about nutting out the history. If somebody presents with vertigo to my rooms, it's 90% of the diagnosis is in taking the history. There's not a huge amount to see on examination, so you've really got to take time and really try and get out the details of their vertigo and what they mean by vertigo. So it's really important, the history, when you're managing patients with vertigo. Of course, they're going to mostly present to their GP. And you're well aware that there are quite a broad range of etiologies, and this can be quite daunting, because somebody can present with acute vertigo and you're going, oh my gosh, is this person having a stroke, or is it something much more benign? But we have to recognize that vertigo can come from ear causes, it can come from brain causes, it can even come from cardiac causes, or even things like anxiety or panic attacks. I've seen patients with very good history of vertigo, just sort of almost like classic Meniere's vertigo, and it turned out that they've had panic attacks. So we've got to think about all those possibilities and what are the red flags in assessment. So if you're seeing somebody who presents to your rooms with acute rotatory vertigo, the things that I'd be wanting to know about is, does the patient have any other neurologic signs or neurologic concerns? So, they've got an acute headache. Do they have evidence of diplopia? Is there ataxia? Something like that, I'd be saying, right, straight to the emergency department. You've got to be worried that this patient's having a stroke. If the patient's getting blackout or has a history of blackout or fainting, there's no ear cause that makes you faint, and certainly doesn't make you blackout. And I have seen over the last 20 odd years, I've seen a number of patients who have come in with a sort of funny history of vertigo, and I'm sort of scratching my head, wondering what it is. And then when the patients come back some time later, they said, oh, yeah, I just got diagnosed with AF. And once that was treated, my vertigo went away. So I'm always, considering that possibility. I think if you're seeing somebody with acute vertigo who's vomiting, who really can't keep down their fluids, and particularly if that's going on for hours and hours, they need to go to hospital. And the other key question to ask about patients, ask patients with vertigo, is hearing loss. Do they have a hearing loss in one ear? Because sudden sensory neural hearing loss can present with vertigo as well. So they're important questions to ask. Oops. if you're seeing a patient who's presenting and they've had vertigo for hours, they've come into your clinic, you obviously need to perform an otologic exam and a neurologic exam, and the recommendation is to perform a HINTS exam. And a HINTS exam is where we perform a head impulse test. There are, you can look up videos on this, but basically we're holding the patient's head, we're asking them to look at the tip of their nose, and we're rapidly making a short, sharp movement of their head to one side, and we're watching their eye. And if their eye lags, and then there's a corrective saccade back to looking at the tip of your nose, that's more likely to be a problem with the inner ear, the labyrinth, so what we call a peripheral cause. If there's no lag, we'd be concerned that that might be a central cause. We want to look at the nystagmus. So again, peripheral causes, somebody with viral labyrinthitis, you know, generally is going to have a unidirectional nystagmus. But if somebody's got a vertical, either an upbeat or a downbeat nystagmus, or they've got a nystagmus in every direction they look and the direction keeps changing, then you've got to be very concerned that that's a central cause. And when we're talking central cause, we're thinking about strokes and that. And then there's this thing called a test of skew, where you alternate coverage of one eye and you ask the patient to look at a spot such as your finger. And as you alternate coverage of their eye, if they've got a central problem, their eye will correct, because it gets out of position when they're only using one eye. You're switching from eye to eye. So HINTS test is quite useful. Takes a bit of practice, particularly doing at the head impulse test, but it's useful. And really what we're trying to do is look for those patients who need a scan because we're worried that they might be having a stroke. So that's really what it's all about, and I'll show you some videos of the vertigo, of the nystagmus. If somebody, however, presents to you in your clinic where they've just got a history of vertigo, you know, one or more episodes, and this is what I'm often seeing in the rooms. You know, it's all about the history, as I said earlier. There's little to find on an examination. We sometimes talk about do investigations, which I'll talk about. When I'm talking about asking the patient about the history, I really want to know, when was their vertigo? What was the duration, which is really important. Was there actual vertigo? Not how long did they feel nauseous, how long did they feel off balance, but how long were they spinning for? And we really divide it up into seconds, hours, or days. Any vertigo that's really only lasting seconds to less than a minute, 99% of the time it's going to be BPPV. If it's lasting hours, they're actually spinning for hours, we'd be thinking of Meniere's disease or vestibular migraine. And if they've got vertigo that's lasting days, we're going to think of viral labyrinthitis, possibly vestibular migraine, or even a stroke. And if they've got, we want to ask about antecedent symptoms. So do they feel the vertigo coming on, or does it hit them out of the blue? Is it associated with positional movement? So classically BPPV, you know, people will say, well, I get it when I roll over in bed, but if I'm sitting still, I don't get it. Are there any other symptoms? And particularly you want to ask about hearing loss. Is the patient getting hearing loss with their episodes of vertigo? Because that's going to, again, think about Meniere's or sudden hearing loss. Do they have post-episode symptoms? Do they feel really wobbly and off balance? Can they not walk a straight line afterwards? I also want to ask about things like tinnitus, sense of fullness, and also about a history of migraine, which is important. And we'll talk about vestibular migraine. I'm going to examine the patient, obviously going to examine their ears, their hearing, going to do their cranial nerves, look for nystagmus. I'm going to do their Dix-Hallpike test. The number of times where I've thought, oh, this patient doesn't have BPPV, and you do a Hallpike, and sure enough, they do. So it's always worth doing because, of course, it's an easily treatable condition. The nystagmus, as we talked about, peripheral nystagmus or ear causes of nystagmus, BPPV is usually a mix of horizontal and torsional components. As I said, it was usually unidirectional. And the other important point with peripheral causes is it usually improves when you get them to fix on something with visual fixation. And as I said earlier, if you start seeing vertical nystagmus, be very concerned about central pathology. There's a few other different types of nystagmus called pendulous. These are periodic, alternating, direction changing. And certainly if it doesn't change with visual fixation, we're thinking about central causes. So this is a little video. This is trying to show some vertical nystagmus. This is really slowed down. And I've got another video which shows much more realistically. This patient's actually got vertical nystagmus, but you've got to look really carefully. But they've actually got a downbeating nystagmus there. So you've got to look very closely, but that's usually indicative of central problems such as a tumor or a stroke. So as I said earlier, sometimes we do investigations. There are certain investigations that we'll often do and certain investigations that we'll occasionally do. So if somebody comes with a history of vertigo, I often want to do their audiogram. From my perspective, that can be indicative of some underlying ear pathology. So I want to do their pure tone audiogram. We always want to ask for their speech discrimination. A fistula test is where they put some pressure in the ear and see if it makes the patient dizzy. And often I'm going to do a scan, and preferentially I'm going to do an MRI scan. Occasionally I might do a CT scan. But as I said earlier, an MRI, if you're going to do an MRI, you want them to do fine slices through the ear. You don't want to just do a broad brain MRI because it will miss things. As far as the whole gamut of what we call vestibular function tests, such as ENGs, calorics, VEMPs, VHITs, these are quite complex tests, and they often actually don't add terribly much to your assessment of a patient who's, with recurrent vertigo. They do have a role, but often not in the initial setting. Sometimes we're doing it where there's a bit of a mixture between potential central causes and peripheral causes. Sometimes we're doing these tests to really assess how much function somebody's got left in an ear, particularly in some cases of Meniere's. But just got to be very careful interpreting these tests because, these tests are comparative tests. Unlike an audiogram, which is sort of a test of absolute how much hearing loss you've got, you can get a percentage hearing loss. Vestibular function tests are actually often comparative tests. So what they're essentially doing is they're comparing one ear to the other, and they're giving you a percentage loss against the other ear. It's not giving you an absolute figure of how much function they've actually got. So if somebody's got loss of vestibular function in both ears, they can give you, some of these vestibular function tests can look normal. So you've got to be a little bit careful about how you interpret them. So we'll just cover a few of the sort of commoner causes of vertigo. So as I mentioned earlier, BPPV is really going to be the commonest thing you'll see when somebody presents with vertigo. Probably over 80% of patients with vertigo in the community, it's going to be BPPV. And it's not associated with hearing loss. Viral labyrinthitis is something that we all get taught about as medical students and everybody's looking out for. Vestibular neuronitis is probably a more correct term to use these days. But that's the acute onset of vertigo, not associated with hearing loss. So that's a very important point. They don't have hearing loss with vestibular neuronitis. And that's where their vertigo is going on for days. And often those patients will end up in hospital. It's usually a once-off episode. They don't get multiple episodes of vestibular neuronitis. Meniere's disease, which we'll talk about. There are some less common causes, acoustic neuromas, which everybody's aware of sort of looking out for. Sudden sensorineural hearing loss with associated vertigo. We treat those patients like sudden hearing loss patients, we give them steroids. It's really the vertigo will settle. It's just a secondary effect. Unfortunately, the vertigo is a bad sign for recovery of their hearing loss. And then there is this condition called superior semicircular canal dehiscence, which can give you some funny symptoms as well. BPPV, as we know, it's a benign and self-limiting condition, no hearing loss. You don't need to do vestibular function tests in these patients. And I've got a little video here. This is what you should be doing when you're doing the Dix-Hallpike test. You can see it's got that torsional component to it. It's fatigable. In other words, if you keep repeating it, it's the ear down that causes the nystagmus is the affected side. And of course, we do the Epley maneuver to address it. Viral labyrinthitis or vestibular neuronitis, I've already mentioned, without hearing loss. Unfortunately, you do have to exclude a stroke in this condition. It does resolve spontaneously. These patients will have a much more, you can see it's a unidirectional nystagmus, and if they look, depends if it's irritative or hyper or hypofunction as to which side's the affected side. And there are some tricky ways to figure it out. But in one direction, it can be more marked. And if they look in the other direction, it may be less marked. And in those patients, if you do vestibular function tests following it, you will see some reduction in function. Acoustic neuromas, which I deal a lot with here at St Vincent, so I'm very aware of them. But interesting, they very uncommonly present with vertigo. Most patients with acoustic neuromas will present with a sense of imbalance. They'll certainly or often present with hearing loss and tinnitus. That's much more common. I've seen a couple of patients who have actually presented with a classic Meniere syndrome, but they don't get acute recurrent vertigo as general. Generally, it'll be more a sense of imbalance. Sudden hearing loss with vertigo, which I've mentioned, and as I mentioned, we've treated with steroids. Superior canal dehiscence. This is basically where the superior semicircular canal is very close to your middle cranial fossa. And if patients missing a little bit of bone off that, it's very hard to see on this scan, their patient's actually missing a little bit of bone off their superior canal. It creates this funny third window effect where patients can get all sorts of strange symptoms, such as hear their voice echo in their ear, gives them this weird apparent conductive hearing loss, can give them this thing called a Chulio phenomenon where a loud noise will actually make them dizzy. And it can give them BPPV-like dizziness. So they'll roll over in bed and they'll get a bit of vertigo. It is something that sometimes we operate on, but not always, because it's a very big operation to fix it. But it is something, just so you're aware of it. And that's a little section on vertigo. So I think, Vanessa.
Thank you. We have a few questions. It's quite a long one here. This is more of like a case study. I had an interesting patient that in the middle of the night developed nystagmus. She slept a few more hours, but when awoke, nystagmus, hopefully I'm saying that correctly, persisted and had severe nausea till an injection of Stemetil fixed the nausea. Slight dizziness. She later developed a non-throbbing headache, past history of migraines and visual aura, but followed by minimal headache or nausea. Could this be vestibular migraine, considering it occurred during sleep when migraines usually improved? The lady was also walking with nystagmus and nausea, vomiting, and had horizontal nystagmus, to clarify.
That's hard one. Look, it's possible. Trouble with vestibular migraine is there's no absolute test for it. Yeah, look, it's a little bit unusual. Horizontal nystagmus can occur in one particular type of BPPV, and certainly patients who wake up with vertigo and nystagmus, often that is BPPV because that's what wakes them up. But if it persisted all night and it was going for many hours, I'd be wanting to look into that. That's not BPPV. On a single episode, it'd be very hard to judge. Recurrent episodes could be many years. I'd be wanting to exclude, I think the patient should have a scan, exclude central causes.
Great. We've got 3 more questions and we'll limit it to that. Second one's from Danielle. What is the best way to do an audiogram on someone with tinnitus?
Oh, just standard audiogram. Tinnitus will have no impact on their audiogram. Just, when we do a pure tone audiogram, we always good to get their speech discrimination as well, because that's sometimes a more sensitive test of their functional hearing.
Another one, you mentioned that vestibular neuritis resolves spontaneously. Does vestibular rehabilitation with a physio accelerate the recovery?
Absolutely, yes, it's very good. The thing with humans is if you lose vestibular function in one ear, because your balance is not just your ears, but it's also your eyes, your proprioception, your cervical spine, your back, your joints, your feet. It's a really complex system. And so what we do, if somebody loses vestibular function or loses function in one ear, we want all their other systems to learn to compensate. So early mobilization is really good. Physio exercise is very good. That's key to getting people up and about.
Sao Yin has said, for otitis effusion post-viral infection, can you treat with nasal steroids or decongestants?
Look, you can. I mean, if it's a post-illness effusion, the nasal sprays, I've got to be honest, I mean, we often give patients a topical steroid nasal spray. I generally don't use decongestants. Time is the big one. A lot of patients will just resolve over time. We know, about 80% of patients will resolve within a month and 90% within 3 months. Time's the big one. If they've had any form of otitis media, the recommendation sometimes is to give a single course of antibiotics. PCR testing of effusions does show bacteria in about 30% of patients.
Thank you. And final question from George Sad. Are vertigo glasses of any proven benefit?
I'm not sure what you mean by vertigo glasses, but I would say no, because I'm not really aware of them.
Okay, not a problem. Next topic, thank you.
All right. So last topic is we'll dive into Meniere's disease. And this is something that it's very important, I suppose, to understand what we mean by Meniere's disease. And you see all these terms thrown about, and Meniere's is a very easy label to remember, but it's thrown about a little bit too much from our perspective. So we try and be very specific. So some of the terms that you might see. So endolymphatic hydrops is really, it's actually a pathologic term. And so what we are talking about is the endolymph, which is one of the fluid spaces within the cochlea and the vestibule. We actually think that the fluid pressure within this space, it becomes elevated, and that's the term hydrops. So it's really poorly understood as to why that happens, but there are some pathologic and radiologic studies to suggest that this is actually what happens. So endolymphatic hydrops we sometimes use when we're talking about patients who have got some Meniere's-like symptoms, but they don't yet meet the criteria of Meniere's. Meniere's disease, of course, is your idiopathic disorder of recurrent vertigo, so 2 or more episodes of vertigo, and they've got to have a hearing loss to make the diagnosis, and we'll come to that. And of course, Meniere's syndrome is essentially a Meniere's disease-like picture, but it has a known cause, such as, the old days it used to be syphilis, but, some sort of pathologic cause that we know of. Lemoyre syndrome, don't get too worried about that. Cochlear hydrops, a bit like endolymphatic hydrops, is sometimes used when we see patients who have a typical Meniere's-like hearing loss, which is a low-tone hearing loss. They might get a bit of fullness, but they haven't had any vertigo. So they've got a hearing loss that looks like Meniere's, but they don't have Meniere's disease. So that's a term that you might see us use. This is actually pathologic slides. If you look down here, this is a sort of cross-section through a cochlea, and we've got the, if you remember your anatomy, the little different components. We've got the scala tympani, scala vestibuli, and the sort of striped area is the scala media. And that's where the inner lymph is. And what we believe in lymphatic hydrops is the fluid pressure becomes elevated, so this becomes dilated here, and it also affects the vestibule. And there are pathologic studies to demonstrate that. So Meniere's disease, as I said, it tends to be overdiagnosed. It's not super common. These are the figures. It's most common in the 4th to 6th decade of life. It can occur in pediatric population, pretty rare. Occasionally it can occur in the elderly. Bilateral disease is uncommon, and there are rare familial cases of it. So what are the clinical features? So we're talking about recurrent episodic attacks of vertigo that are not provoked. So they're not positional. They're not related to doing something. And by definition, you know, they're lasting hours, you know, so more than 20 minutes, and generally will last less than 24 hours. So somebody who's had acute vertigo for 3 or 4 days, that's generally not Meniere's disease. Often associated with nausea and vomiting, but not always, especially in the advanced stage. And as I said, they get a characteristic hearing loss. And the key feature of Meniere's, and to make the diagnosis, is you've got to see this low tone hearing loss. As you know, presbyacusis affects the high frequencies, but it's the low frequencies and sometimes the mid frequencies that you've got to see that. And, you know, Meniere's like, it's a real spectrum condition. And I've seen patients who have presented initially with a low tone hearing loss and then later presented with episodes of vertigo. And then you make the diagnosis. The classic, of course, is the patients get some episodes of vertigo, they don't get any hearing loss, and then later they get the hearing loss, and then we go, aha, you know, you really do have Meniere's disease. And so the hearing loss is not only low tone, but it can also be characteristically fluctuating. So patients will get hearing loss that will go up and down. And in true Meniere's disease, often the hearing loss will progress, and they'll end up with this very flat 60, 70 decibel burnt out phase hearing loss, which we'll come to. And poor speech discrimination is often a feature, which we'll also talk about. As you know, a lot of patients will get a sense of pressure or fullness. The tinnitus can be sometimes characteristically described as a roaring sound. And certainly patients with Meniere's can get an exacerbation of their tinnitus associated with the episode of vertigo, or just preceding, or just immediately preceding the episode of vertigo. So they'll get their tinnitus they'll have a background tinnitus all the time, and then they'll get a flare up of their tinnitus with their vertigo. Recruitment is sometimes seen in certain types of hearing loss where I wouldn't get too worried about it, but Meniere's can give some funny types of features of hearing loss. Now this is in here. This is showing this is the absolute classic Meniere's, and most people won't actually end up seeing this. You really only sort of see these phases of nystagmus if you actually have somebody with the goggles on when they're having an episode of vertigo, which of course very rarely happens. So this is sort of stuff that sometimes I see in the labs, but it's not. I wouldn't get too worried about the different phases of vertigo and nystagmus, because you've got to sit there and watch them for hours to actually see the different phases. The other thing that people know about is something called a drop attack. It's also known as a Tumarkin crisis. And this is a very, very uncommon and very severe version of Meniere's, where they basically lose control of all their axial muscle input due to a sudden change in vestibular function. And the patients get this sudden drop to the ground, and it's really dramatic. And the important thing with it is they do not lose consciousness. They are not fainting.
they're awake the entire time, but 1 minute they're standing, next minute they're on the ground and they're going, what's happened? And we're very concerned about drop attacks because they're dangerous. If that occurs at the top of a flight of stairs or something like that, patients can do themselves a major harm. Now, it's very, as I said, it's very rare, but it is something to be, to know about. And if we see people with drop attacks, we generally treat them quite aggressively. So the natural history of Meniere's, and it's described to have this sort of natural history. So the classic is they'll get their episodes of vertigo, intermittent symptoms. Sometimes they'll come in runs where they'll get frequent episodes. And it is a condition where they can get a bout of episodes and then the episodes can stop. And sometimes the episodes can stop for years. I've seen patients who present in their 70s, they're getting acute episodes of vertigo, and you go through their history and they say, oh yes, back in my 30s, I had a few bouts of vertigo. Nobody knew what it was. It went away. And in fact, it was probably their Meniere's disease starting 30 years ago. It just was quiescent for a long period of time. Then they often will start to get some hearing changes. As I said, that fluctuating hearing. An ECOG's a type of test. Don't get too worried about that. Stage 2 is where they get a more permanent hearing loss. And it makes it easier to actually confirm the diagnosis because you tend to see the hearing loss. And again, they can still get episodes of vertigo. And then the last stage of what we call the burnt out phase is where I said they get a very flat, severe hearing loss. It plateaus out at about 60, 70 decibels. And interestingly, in a burnout phase, the patients actually don't get acute episodes of vertigo anymore. They might still get a sense of pressure. They might get a sense of fullness. They might feel a little bit wobbly, but they don't actually get true vertigo. And occasionally you'll see the drop attacks. I don't want to labour that point too much. So it's important to understand there are diagnostic criteria for making the diagnosis of Meniere's disease. And these are the American Academy guidelines that we use here in Australia. So they've got to have 2 or more episodes of vertigo lasting 20 minutes to 12 hours. They've got to have a low to mid-frequency hearing loss in one ear during or after the episodes of vertigo. Fluctuating symptoms, we've talked about that sense of pressure, some tinnitus, and importantly, it's not better accounted for by any other vestibular diagnosis. So that's definite Meniere's. So when they've got the hearing loss, that's the key feature. So this is what we're talking about, this low frequency hearing loss that you might see. Then you've got something called probable Meniere's. And this is the patient you'll see who's had a couple of episodes of vertigo, but they haven't had hearing loss. And you're looking at them going, oh, well, it could be Meniere's, it could be something else. They might have a sense of pressure. And this is what we call probable Meniere's. When you see those patients, of course, you've got to think of other possibilities. And there's a broad range of differential diagnoses. I don't want to get too heavily in all these different possibilities, but I will talk about vestibular migraine because that is an important differential. This is another slide just talking about all the potential differentials and how we might differentiate Meniere's disease from all these sorts of other things. As I've said earlier, BPPV, it's going to be vertigo that's seconds to a minute. Vestibular migraine can be the hard one to pick. And things like labyrinthitis, vestibular neuritis, their vertigo goes for days and days. So vestibular migraine is a subtype of migraine where patients get acute vertigo, but they don't really get much in the way of headache. And some don't get any headache at all. It's a clinical diagnosis. There is no test that proves migraine. Some of their vertigo typically can last hours, so it can really look like Meniere's. It can be difficult because, we know that stress can bring on Meniere's episodes, stress can bring on migraine episodes. Meniere's patients, when they get the acute episode of vertigo, often say, oh, if I go and have a lie down and a sleep, it'll pass and then I'll feel better. And the same thing happens in migraine. They go down and have a sleep, it passes, they feel better. But vestibular migraine is something to be aware of as a potential cause of acute episodes of vertigo, recurrent episodes of vertigo that are lasting hours. So it is something that we think about. It's a real overlap area with the neurologists. And more, we are seeing, you might be aware there's some very good vestibular neurologists around Sydney, but we're seeing there's a trend towards some diagnosing some patients. There's a lot of overlap between Meniere's and migraine, and a lot of these patients have very similar features. And we do think that there are some patients who probably have some Meniere's, and they've also got a bit of migraine as well, and it can be very confusing and quite challenging to manage. These are the Barani diagnostic criteria for vestibular migraine. But you are looking for things like headache. I often ask them about things like photophobia. Often the headache's not a big thing, but I'm often asking them, do they get sensitive to loud noise? Do they get sensitive to light when they get these episodes? And often, of course, the patient's got a history or a family history of migraine. So I think they're the key things that I'm thinking about when I'm thinking about vestibular migraine. And of course, the key thing is that they don't have a hearing loss. Vestibular migraine, they don't get any hearing loss with this. So that's the differentiating feature. So investigations for Meniere's, a hearing test we've talked about, very useful, very hard to get an acute episode hearing test, but of course over time they'll get this and this progresses. And here you can sort of see it tends to, their burned out phase tends to flatten out here. And one of the characteristics, as we mentioned earlier, is they get poor speech discrimination. So the trouble with poor speech discrimination, it means that if you turn the volume up, you don't hear any better. And these patients can be very hard to aid because making it louder doesn't make it clearer. It tends to actually make it more distorted. So there can be a real challenge from an audiologist perspective to aid. If I see somebody with recurrent vertigo, as I mentioned earlier, we can do MRI scans. Generally, we're doing an MRI to rule out other pathology. But if you want to be really clever, you can do these contrast delayed phase MRIs, which are quite complex to do. And you've got to ask the radiologist specially to do it because they basically inject contrast and then they get the patient back 4 hours later. And you can actually, if you look very carefully in some patients you can see the cochlear hydrops with the dilation of the scala media, and you can make that diagnosis. We generally don't do this test very often unless we've got a very confusing patient where we're really unsure as to what's going on. Generally, you just do an MRI to make sure they don't have a tumor or MS or something like that. Vestibular function tests, which we've talked about. Generally, I don't order vestibular function tests in Meniere's patients unless I'm going to think about an operation, particularly what we call an ablative or destructive procedure. And then the purpose of the vestibular function test is to make sure that their other ear is functioning okay. What we want to know is that have they got good vestibular function in their other ear so that they can compensate? That's the main role. There's not if somebody presents with classic vertigo, classic low tone hearing loss, doing vestibular function tests doesn't really help you terribly much. Sometimes I should add, sometimes in the vestibular migraine patients where we're still not sure, sometimes we might do it in those patients to see if we can come up with the diagnosis. So we'll move on to management. So management is complex. The goals of management, you've got to think about what are the goals of managing these patients. Generally, the vertigo is what's upsetting them. So you're aiming to reduce the severity and the frequency of their attacks, and you're trying to improve this patient's quality of life. We've got to address the hearing, the tinnitus, their imbalance. And, the vertigo is a thing that they'll want you to try and treat. But interestingly, it's also the symptom that will, with enough time, will eventually settle. Imbalance, if somebody loses balance function in one ear, they can be left with a slight imbalance long term. Generally, they'll compensate. Hearing loss is a challenge because often it progresses and often we can't stop it progressing, but there are options to manage it. The patient's sense of fullness and pressure, unfortunately, we don't really have anything great to reduce that. Short of doing a full labyrinthectomy on a patient's ear, it's very hard to get rid of that. And the tinnitus we've talked about, again, it's management of the tinnitus. So when we think about treating the vertigo, we're thinking about treating their acute phase versus their longer term. So there are a range of treatments. The things that I think about, so if somebody's presenting to you and saying, okay, well, you think it's Meniere's, what can I take for my, when I get another episode? The standard sort of treatments, we want to give them the sort of antiemetic, so that try and avoid vomiting. The trouble is, once a patient starts vomiting, of course, they're not going to keep any medication down. That's sometimes where Zofran wafers can be quite useful. Phenergan is quite good for very bad vertigo. It does have that sedative effect, but it's a really good vestibular suppressant. You may be aware of this drug called Sinarazine. Stugaron's not very available in Australia. It's available overseas, but there is a version of it available in Australia called Cisinate, and there are some patients who seem to respond to that. And then the old school treatment of diazepam does actually work in some patients for their acute vertiginous episodes. I don't believe Circ actually has much role. It's a very benign drug. Lots of people use it, but for my mind, Circ is a long-term medication trying to reduce the frequency and the severity. When you actually think about what is Circ supposed to do, I don't see how it can actually reduce vestibular function and abort an acute episode. If somebody gets an acute major hearing loss, sometimes we can give them steroids. As I mentioned earlier, often they'll go down and have a lie down. I think one of the keys in managing patients with recurrent vertigo is you've got to get them to have the right attitude. And they've got to accept the fact that they might get an episode, it's going to affect that day, but it doesn't mean they can't get back to normal activities the next day. And you've got to try and alleviate their stress and their worry. And I like patients to try and keep a bit of a diary of my major and minor episodes. A major episode we classify as an episode that they have to stop doing what they're doing. They have to lie down. Whereas a minor episode is an episode where they feel a bit wobbly, feel a bit off balance, but they keep doing what they're doing. There are all sorts of guides and stages, and I'm just showing this to show you what's available. But to be honest, we don't get too caught up about all these gradings and things like that. What I like to do when I'm managing patients or giving them a medication or a treatment for their recurrent vertigo in their Meniere's is we're looking at reducing the frequency and severity of their major episodes over a period of time. So I'm asking the patient, how many episodes have you had in the last 3 months or 6 months? Then you commence a treatment. Then you're looking at what their response is. If they had 6 episodes in 6 months, and then you commence treatment, and then they've only had 1 episode in 6 months, they've still had an episode, but you've made progress. There's a real subjective element to this. Time is a big thing in treatment of Meniere's. You're not going to solve their problems overnight. If you see the unfortunate patient with bilateral disease, that's a real problem. They are very difficult to manage because it removes our option of destructive procedures. And as I said earlier, consider coexistent migraine, because we know patients with a history of migraine, it tends to really exacerbate their symptoms and drive their symptoms, and it can make them a little bit more difficult to manage. So this is our standard ENT treatment ladder of starting in the bottom left, the simplest treatments, to the top right, which is the most aggressive treatments. And I've sort of tried to classify the sort of green, these are medications. So reassurance, low salt diet. Some people use diuretics, some people use beta histine, sometimes oral steroids. When you look at these conservative treatments, or what we call conservative non-destructive treatments, the success rate for any one of those treatments in the literature is about 60 or so %. So about 60% of your patients will respond. There are greater interventions that we sometimes consider, grommet, injecting steroids, and then what we call these destructive procedures. And in fact, I've simplified it to what I actually would do. This is the order of things that I would do. So I'd certainly talk to the patient, reassure them. I think reducing the salt in their diet's always good for the patient. It's a good weight loss program, good for their blood pressure. I don't put them on a low salt diet and a diuretic. I talk to them about the importance of not excessive water intake on a low salt diet. Always try that first. I'll certainly try Circ. Circ's a very benign drug. You've got quite a broad dose range with Circ, so you can muck around with that for a bit. Sometimes if patients are getting a run of lots of episodes of vertigo, I might give them a very short course of steroids just to see if we can break up those episodes. As I said, some people use diuretics. If you actually look at the evidence, the Cochrane collaboration has shown that it's not effective, but you know, like everything in medicine, you know, there are some patients who seem to like their diuretics and respond, so it is used. From our perspective, sometimes we will again inject steroids in their ears, intratympanic dexamethasone. Sometimes that can be useful to break up acute episodes of vertigo. Grommets have been used since the 1960s. Don't ask me, nobody knows how they work or why they work, but there are some patients who respond to a grommet. And then if we get really severe cases of Meniere's where patients are getting housebound, they can barely cope with it, we'll look at a labyrinthectomy. We'll either inject gentamicin in the middle ear like we do with steroids, and that's a chemical labyrinthectomy, or we'll do a surgical labyrinthectomy where we'll literally drill out their labyrinth. And if we do that, we're destroying the remaining hearing. And in those cases, we'll put in a cochlear implant at the same time. So that's our sort of treatment ladder. So as I said, there are what we call non-destructive treatments. So there's the surgical treatments that we do as ENT surgeons. So we might inject steroids, insert a grommet. And then the destructive treatments. The destructive treatments, this is the time we do vestibular function tests. We really want to avoid destructive treatments in bilateral disease, because if you've got damage to both labyrinths, that can really disable people. So that's a real issue. A little point when it comes to giving medications like Circ and that, people have different approaches. I don't think there's any right or wrong. Some people start at a low dose and work their way up. Some people will start at the maximum dose and work their way down. I do try to avoid multiple treatments at once. I think if you just sort of use this shotgun, you give them 10 different treatments, they get better. You really have no idea as to what made them better. So I try and, progress. I think you've got to explain to the patients that the hearing loss will often progress, and, often they'll end up with a significant hearing loss no matter what you do. I think time's a very important thing in treating patients with Meniere's. You're not going to solve their problems overnight. I like to review patients in blocks of time in either 3 months or 6 months. You've really got to try and get the patient to persevere and stick at it, because a lot of patients with time will actually improve. And the frustrating aspect of this condition is you can do nothing and some patients will get better. You can do everything and some patients won't get better. But we know that a lot of patients will get to that burned out phase eventually, and so their vertigo will stop. Now, whether or not it takes, 2 years, 3 years, or 20 years that's the hard thing. And so sometimes we feel that what we're doing with treatment is trying to speed up them getting to that end phase. But it is interesting that a lot of patients will get better no matter what you do. And I think that classic saying of Voltaire, where the art of medicine consists of amusing the patient while nature cures the disease, has a little element of truth when it comes to treating Meniere's disease. So thank you very much for your time, and hopefully I haven't run over and exhausted people too much.
Thank you so much. We have 2 questions at the moment. The first one, a patient took paromycin, probably similar to gentamicin, for a GIT parasite, Dientamoeba fragilis. It is not supposed to be absorbed. The patient soon after taking it was noted to have reduced hearing and had documented sensorineural sensorial hearing loss, mainly in one ear. Previous normal colonoscopy. Has the speaker come across this problem with ototoxic drugs not supposed to be absorbed?
No, but we're always suspicious. You know, vancomycin's the other one that they give as a gut tablet without absorption. I think any of the aminoglycosides, there are a small percentage of patients who have a mitochondrial DNA abnormality, which makes them susceptible to sensorineural hearing loss with a single dose of an aminoglycoside. I haven't heard of paramycin or that run across that. I mean, generally but we definitely see patients who get a single dose of aminoglycoside and will suddenly lose vestibular and hearing function because they've got this, and I can't remember the gene mutation, but it's a mitochondrial gene mutation occurs in a small percentage of patients.
Thank you. And from George Sad, is ginkgo biloba of any proven benefit for tinnitus/vertigo?
No. 30% of patients respond to ginkgo, and what's placebo rates 20-25%. I think personally, I think ginkgo for tinnitus is suggesting to the patient that there's a tablet out there that they can take for their tinnitus, and when they fail with their ginkgo, they're looking for the next tablet, and then you've got to try and de-escalate the whole thing. So I really try and avoid that. Certainly no role in Meniere's or vertigo that I'm aware of. From my perspective, it's a low risk medication, but I don't think there's any. I think all the studies don't show any scientific basis. There's no evidence base to it.
Great, thank you. That's all the questions we have. Does anyone else have some final comments or questions that they'd like to pose to Associate Professor Biggs? Well, we've got one here. Does sound therapy help tinnitus?
It a little bit. Depends what you mean by sound therapy. As a form of masking, yes. I think there are some devices out there. So there's something called Neuromonics, which is a device that's supposed to play a certain sound, which is customized to your hearing loss. It's a device with 6 months of counseling. Personally, I think it's the 6 months of counseling that actually works. I'm not so convinced about the device. So really, yeah, there's no strong evidence that there's any particular device that producing sound that is, apart from masking, that is going to reduce tinnitus.
3 questions. One from Asha. Do diuretics play a role in Meniere's?
Yeah, look, as I said, they do. I mean, there are definitely some patients who seem to benefit from diuretics, particularly if they can't manage a low salt diet. I'm not a big fan of it. The evidence is not strong for diuretics. As I said, the Cochrane collection doesn't show any evidence for it, but there are some patients out there who seem to benefit. I generally would use a potassium sparing one such as Moduretic. And I've certainly had some patients on diuretics who have then run into side effects of the diuretics and had to stop the diuretics. So, but it has a small role.
We have 2 final questions from an anonymous person. What do you see the role of vestibular rehab in Meniere's disease?
Less, I think it's certainly for a patient who's losing their confidence, it can be quite useful to give them some structured exercises to get them sort of back on the horse, so to speak, and get them out and about. The trouble is if they're in that sort of earlier phases where their vestibular function is fluctuating, their brain can't really adjust, and so it's hard to adapt. Vestibular rehab's really good when your loss of vestibular function has stabilized. When you get fluctuating function, it's hard to make a huge impact. But look, there's certainly no harm in doing it. But yeah, if they're in the early phase, it can be a little bit difficult.
And the final question for this evening, is there any correlation between tinnitus and cardiac issues?
Not apart from some cardiac medications can be associated with tinnitus. Not particularly. There was a study many years ago suggesting there was a weak association between high cholesterol and tinnitus, but nobody knows why. And there's no evidence that reducing a patient's cholesterol gets rid of their tinnitus. But no, apart from the fact that physical stressors exacerbate tinnitus and some cardiac diseases are physical stressors.
Fantastic. We do have another question as well. Should we do an MRI on everyone with tinnitus, acoustic neuroma, rare cause, or just unilateral tinnitus?
I think it depends on the patient. So if it was a new onset, persistent, constant, persistent tinnitus, particularly in a young person, look, you know, it's very defensive medicine. I probably would. If it's bilateral or central tinnitus, I would not. So yeah, a unilateral. I think if you've got if you've got a 90-year-old who suddenly presents with a bit of tinnitus and they've got a known underlying sensory neural hearing loss and they're wearing hearing aids, you know, you can really make the argument, is an MRI going to make any difference? So I think a little bit depends. You've got to use a bit of clinical judgment there. But if it's bilateral, I certainly don't see any role for doing an MR.
A question from Asha. Aspirin and tinnitus relation.
So high dose aspirin will cause tinnitus. It's a well-recognized drug effect. There's a number of, as you might know. So high dose aspirin, if you take 12 aspirin a day for a few days, most people will get tinnitus, but it's dose related. A lot of people with tinnitus get told not to take non-steroidals. Whether or not it truly exacerbates their tinnitus is very individual. I wouldn't stop somebody with tinnitus taking a non-steroidal. But yeah, high doses of aspirin, absolutely. We also know high doses of erythromycin can cause tinnitus. High doses of tegretol causes tinnitus. High doses of Lasix cause tinnitus. So there's a number of drugs in big doses that will cause tinnitus, which is dose related.
And one more question. Loud noise, example, flying on planes, makes the patient's tinnitus worse. What earplugs, etc., help the most?
I think for things like airplanes, noise cancelling is probably your best bet. You know, be it headphones or noise cancelling earplugs or headphones. Aircraft are quite amenable to really, because they've got a fairly constant background noise. So noise cancelling is really good in that situation.
I think that's it for this evening in terms of questions. Thank you so much, Associate Professor Nigel Beats.
I didn't know if anybody wanted to cover those or not.
If anyone has any further questions, please feel free to email Bertha, who can share them, and we can get in touch with Professor Biggs, who can answer them, or pass on your contact details, actually.
Yeah, no, very happy to.
Wonderful. Bertha?
Thanks, Vanessa. Thanks so much for organising tonight's talk, and thank you to Associate Professor Biggs for his time tonight and a very practical presentation. Again, thank you everybody else for joining us this evening. Please stay online to fill out the evaluation survey and visit our website for more upcoming events. Thank you again and enjoy the rest of your night.
Thank you. Bye.